Welcome to another deep dive. Today we're going to be focusing on upper respiratory tract infections, those pesky bugs that keep us medical microbiologists busy, especially during certain times of year.
Oh yeah, those URTIs keep us on our toes, that's for sure.
Definitely. So to guide us through this deep dive, we've got this really interesting AI Gemini document.
Well, it's pretty comprehensive.
Yeah, and by the end of this, I'm hoping we can kind of come up with like an algorithm, something to really streamline how we approach URTI analysis in the lab.
A step-by-step approach. I like it. Makes things much clearer, especially for those tricky cases.
Totally. Now, before we get too deep into the URTIs, the document starts off talking about lower respiratory tract infections, and I figured we should touch on that first.
Good point. It's all connected, right? The respiratory system, I mean.
Exactly. So what are some of the key things that stood out to you about the LRTI section?
Well, one thing that struck me was just how diverse these infections can be. It's not just pneumonia, though it's a big one, of course.
Right.
But you've also got bronchitis, pleuritis. It's a whole spectrum, really, depending on what bug is causing the trouble.
And speaking of bugs, when it comes to LRTIs, there's kind of a familiar cast of characters, right?
Oh, absolutely. The usual suspects are usually lurking around.
Like who? Give us the rundown.
Well, Streptococcus pneumonia is, like, the headliner,
Wow.
especially in community-acquired cases.
Yeah, good old pneumococcus. Always causing a ruckus.
But here's the thing. Even a common bacteria like S. pneumonia can sometimes throw us a curveball in the lab.
A curveball, huh? Now you've got me intrigued. What kind of curveball are we talking about?
Well, you know how S. pneumonia is typically gram-positive? Those nice Diplococci.
Classic textbook picture.
Right. But sometimes that thick capsule they have can actually make them look gram-negative on the stain.
Oh, wow, really? So it's like a disguise.
Kind of. It's a good reminder that we can't always rely on the gram stain alone.
Definitely. Got to keep our eyes peeled for those sneaky bacteria. Okay, so we've got our gram stain, but the document also talks about this Q-score system for sputum analysis. What's that all about?
Ah, yes, the Q-score. It's all about making sure we're looking at the right cells. The ones actually involved in the lower respiratory tract infection.
So it's like a quality control check for the sputum sample.
Exactly. It's a ratio that compares the number of epithelial cells to white blood cells.
So a low Q-score means we're good, right? Less contamination from the upper respiratory tract.
You got it. A low Q-score gives us more confidence that the bacteria we isolate are actually causing the problem in the lower airways.
Okay, that makes sense. So we've got the gram stain, the Q-score. What other diagnostic tools are we using for LRTIs?
Well, culturing is still king, right? We've got our blood agar, chocolate agar, but sometimes we need to get more specific with our media.
Oh, absolutely. The document dives into some of those trickier pathogens that need a little extra attention. What are some examples that come to mind?
Well, Legionella, for one. It's notorious for causing those severe pneumonia cases, and it needs a very specific medium to grow.
Yeah, Legionella is a tough one. What kind of media are we talking about?
We often use buffered charcoal yeast extract agar, or BCYE agar. It's got the goodies that Legionella loves.
BCYE agar. It's like a five-star hotel for Legionella.
Yeah.
What about pathogens that are even harder to grow? Like
Yeah.
Mycoplasma pneumonia? That one's always a headache.
Oh, tell me about it. Mycoplasma pneumonia. It grows so slowly, and it can be really tricky to culture.
So what do we do in those cases?
Well, often we have to rely on serology or molecular methods like PCR. Sometimes culture just isn't feasible.
So we have to adapt our approach. All right, so we've laid some groundwork with the LRTIs, but let's shift gears now and focus on the main event, upper respiratory tract infections. What are some of the major players we encounter when we're dealing with URTIs?
Well, unlike LRTIs, which are mostly bacterial, URTIs are often caused by viruses, like those rhinoviruses and coronaviruses that give us the common cold.
Yeah, those viruses love to make the rounds, especially during cold and flu season.
But bacteria can definitely crash the party, too.
That's right. The document mentions a few specific bacteria that are common culprits in URTIs. Can you give us the lowdown on those?
Sure. One of the big ones is Streptococcus pyogenes. That's the one that causes strep throat.
Oh yeah, S. pyogenes is definitely a troublemaker, and it's important to catch that one early because of those potential complications, right?
Absolutely. Rheumatic fever is a serious concern if strep throat isn't treated properly, so we need to be on the lookout for that.
Okay, so S. pyogenes is one to watch out for. What about other types of URTIs, like sinusitis? What bacteria are usually involved there?
Well, sinusitis can be caused by a few different bacteria. Streptococcus pneumoniae is one, Haemophilus influenza is another. And then there's Moraxilla catarrhalis.
Those names sound familiar. They pop up in other respiratory infections too, right?
Yeah, they're kind of like the repeat offenders of the respiratory tract. They love to cause trouble in various places.
It's like they've got a map of the respiratory system and they're just hitting all the hot spots.
Exactly. It's important to consider the whole clinical picture to figure out what's going on.
Definitely. Now, the document also talks about some less common but potentially very serious URTIs, like epiglottitis. Can you tell us a bit more about that one?
Epiglottitis is a scary one. It's an infection of the epiglottis, which is that flap of tissue that covers your windpipe when you swallow.
Oh, right, the epiglottis. I remember learning about that in the anatomy class.
And if it gets infected, it can swell up and block the airway. It can be life-threatening, especially in young children.
So that's definitely one we want to catch early. What bacteria typically cause epiglottitis?
Well, it used to be mainly Haemophilus influenza type B, or Hib, but luckily, thanks to vaccinations, we see that one much less often these days.
Vaccines doing their job. That's good to hear.
Definitely. But other bacteria can still cause epiglottitis, so we can't let our guard down completely.
Always got to stay vigilant. Okay, before we move on to case studies, I want to touch on ear infections. The document talks about two types, otitis media and otitis externa. Can you explain the difference?
Sure. Otitis media is an infection of the middle ear, that air-filled space behind the eardrum.
Right, I've heard of that one.
It's super common in kids, and it's usually caused by the same bacteria we see in sinusitis: Streptococcus pneumonia, Haemophilus influenza, and Moraxilla catarrhalis.
Ah, those guys get
Yep, they get around. Now, otitis externa is different. It's an infection of the outer ear canal, the part you can see and clean.
So one's behind the eardrum and the other's in front of it. Makes sense. What about the bugs that cause otitis externa? Are they the same as in otitis media?
Not always. While those three bacteria can also cause otitis externa, we often see Pseudomonas aeruginosa in those infections, especially in cases of swimmer's ear.
Swimmer's ear. Ah, yes. That's when water gets trapped in the ear canal after swimming, right?
Exactly. It creates a nice little breeding ground for bacteria.
Makes sense. Okay, so we've got a good handle on the players involved. Now let's talk about diagnostic procedures for URTIs. Are they similar to what we do for LRTIs?
There are some similarities for sure. We often start with a good look at the affected area. Like for pharyngitis, we'd look for redness, swelling, maybe some pus on the tonsils.
So using our eyes as a first line of defense.
Absolutely. And then, depending on what we see, we might use imaging studies, like an X-ray or CT scan for sinusitis.
Right, get a better view of what's happening inside. What about cultures? Are those as important for URTIs as they are for LRTIs?
Definitely, especially when we suspect a bacterial infection. For example, if we think it might be strep throat, we'll do a throat swab to check for Streptococcus pyogenes.
So cultures help us pinpoint the culprit and make sure we're using the right treatment.
Exactly. It's all about getting the right information to make the best decisions for the patient.
All right, it sounds like we've got a good foundation laid for understanding these URTIs. Now, how about we dive into some case examples and really put our knowledge to the test? Are you ready for a challenge?
Bring it on! I love a good case study. It's like solving a puzzle.
All right, let's get those detective hats on and see what we can crack. Okay, so case number one. Imagine you've got this worried parent coming in with their little one, like a 3-year-old who's been cranky, running a fever, and tugging at their ear. Oh, and there's a bit of a cough too. What's your first thought?
Oh, a 3-year-old with those symptoms. My brain immediately goes to otitis media. It's so common in that age group.
Otitis media. Classic ear infection, right? But wouldn't we have to consider other things too?
Oh, definitely. We can't rule out other possibilities like a viral URTI or even pharyngitis. Got to keep an open mind.
So, multiple possibilities. But otitis media is a strong contender. What would you do next to really nail down the diagnosis?
Well, a good ear exam is key. We're looking for that telltale redness, maybe some bulging of the eardrum, and if it's not moving as much as it should, that's another sign.
So you're looking for those classic signs of inflammation, right?
Exactly. And if the exam points to otitis media, we've got our usual suspects, those bacteria that love to cause ear infection.
Oh, you mean like Streptococcus pneumonia, Haemophilus influenza, and Moraxilla catarrhalis?
Those are the ones. Knowing who the usual culprits are helps us get a head start on treatment.
Makes sense. Okay, moving on to case number 2. Let's say we have a teenager, maybe 17 years old, complaining of a sore throat, fever, and just feeling blah. You take a peek, and their tonsils are swollen with those white patches. What's your gut feeling?
A teenager with white patches on their tonsils. That screams pharyngitis to me. And with that classic presentation, Streptococcus pyogenes is at the top of my suspect list. The one that causes strep throat.
Ah, strep throat, a classic. So how do we confirm it's S. pyogenes causing the trouble?
We'd do a rapid strep test or a throat culture. Those tests will give us a definitive answer.
Gotta love a good lab test to give us some certainty.
Mm-mm.
All right, case number 3. We've got a 45-year-old woman coming in complaining of a headache that just won't quit. Her face hurts, especially when she leans forward, and she feels pressure behind her eyes. On top of that, she's got nasal congestion and her sense of smell is off. What are you thinking?
With those symptoms, sinusitis is the prime suspect. The pain location, the congestion, the smell issues, it all fits.
Sinusitis, another common one. So what bacteria should we be thinking about here?
Well, it's often those same troublemakers we've been talking about. Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. They just love the respiratory tract.
They really do get around.
Yeah.
Now, for case number 4, picture this. A 70-year-old man, smoker, comes in with a cough that won't quit, feeling short of breath and running a fever. He mentions that his grandson, who had a cold, recently visited. What are your initial thoughts on this one?
Okay, this one's a bit more complicated. With his age, smoking history, and that recent exposure, we need to think broader. Could be bacterial, could be viral.
So what are some of the possibilities we should consider?
Well, pneumonia is definitely on the list. Could be community-acquired or even aspiration pneumonia. And we can't rule out influenza or a bacterial complication from his existing lung issues.
So a lot of potential culprits here. How would we go about figuring out what's going on?
We definitely need a chest x-ray to check for pneumonia. And we'd want to get some sputum samples for culture and gram stain. Influenza testing wouldn't hurt either. And if we're worried about a more serious systemic infection, blood cultures would be a good idea.
So a multi-pronged approach to get to the bottom of things makes sense. Okay, last case. Imagine a 2-year-old child being brought in with a fever, struggling to breathe, drooling, and with a muffled voice. The child is visibly anxious and sitting upright, leaning forward. This sounds pretty serious. What are you thinking right away?
This is ringing all the alarm bells for epiglottitis. The child's posture, the drooling, the breathing difficulty, it all points to a potentially life-threatening infection of the epiglottis. This is an emergency. We need to act fast.
Definitely sounds like a time-sensitive situation.
Yeah.
What are the most critical steps in managing this kind of emergency?
Airway, airway, airway. That's our top priority. We need to make sure the child can breathe, so we need to be ready to intubate if necessary. And we'd start antibiotics immediately, broad-spectrum ones, to cover the most likely bacteria, even before we have culture results.
So airway management and hitting it hard with antibiotics are key. Would we even try to get a throat culture in this scenario?
We'd want to, yes, but not if it delays treatment. Securing the airway and starting those antibiotics takes absolute priority.
Wow, those cases were intense. It's a good reminder of how quickly things can escalate with these infections. Now, how about we switch gears a bit and do a rapid-fire Q&A? I've got 10 exam-style questions to test your knowledge. Ready to put on your thinking cap?
Hit me with your best shot. I'm ready to put my knowledge to the test.
All right, question number 1. Which bacterium is the classic culprit behind scarlet fever?
That would be Streptococcus pyogenes. Scarlet fever is like a bonus feature you get with strep throat, complete with a rash.
Correct. Okay, next one. What test do we use to confirm if Streptococcus pyogenes is hanging out in a throat swab?
We've got 2 options, a rapid strep test, which gives us a quick answer, or a throat culture, which takes longer but is more definitive.
Perfect. All right, question 3. What's the key difference between sinusitis and rhinitis?
That's all about location, location, location. Rhinitis is inflammation of the nasal passages, while sinusitis is when the sinuses, those air-filled spaces in the skull, are inflamed.
You nailed it. Okay, question 4. What's that little flap of tissue called that covers our windpipe when we swallow?
That's the epiglottis, and as we saw, if it gets infected, things can get very serious very quickly.
You're on a roll. Question 5. What's the common name for otitis externa, that pesky ear infection?
That's swimmer's ear. Water gets trapped, bacteria move in, and trouble ensues.
Correct. All right, question 6. What's the usual approach for managing most cases of acute otitis media in children?
Well, it depends on a few things, but often we start with watchful waiting or just focus on managing pain. Sometimes the body can fight it off on its own.
Good point. Question 7. What virus loves to cause infectious mononucleosis, also known as the kissing disease?
That would be the Epstein-Barr virus, and it sure gets around.
Correct. Okay, question 8. What's that procedure called where we get to peek into the airways and snag some samples from the lower respiratory tract?
Ah, you're talking about a bronchoscopy. It's like a little camera journey into the lungs.
Exactly. Okay, 2 more to go. Question 9. What does it mean if we see gram-negative diplocacci in a cerebrospinal fluid sample?
Uh-oh, that's bad news. It usually means we're dealing with Neisseria meningitis, which causes
Yeah,
meningitis.
you got it. And for our final question, how do those beta-lactam antibiotics like penicillin and cephalosporins work their magic against bacteria?
They're like tiny construction workers, but instead of building, they mess things up. They inhibit cell wall synthesis, which basically weakens the bacteria and leads to their demise.
Bravo. You aced the Q&A round. You've definitely got a solid grasp on these URTI concepts.
Thanks. It's always good to refresh the knowledge and make sure it's all up to date.
Absolutely. Now, before we move on, I want to highlight something important from the AI Gemini document. It stresses how crucial it is to consider the whole patient picture when dealing with URTIs. Their medical history, how strong their immune system is, any potential exposures they've had. What are your thoughts on that?
It's absolutely essential. The same bug can cause a totally different reaction in different people. Take a simple cold virus. It might just be a minor annoyance for most. But for someone with a weakened immune system, it can be a serious problem. We need all the pieces of the puzzle to make the right call.
It's all about personalized medicine.
Exactly. Treating the patient, not just the infection.
Okay, before we wrap up this part, I've got one last thought-provoking question for you. How do you see the whole field of URTI diagnostics changing in the future? What new technologies or approaches are you excited about?
That's a great question. I'm really excited about the potential of rapid molecular diagnostics. Imagine being able to pinpoint the exact pathogen in minutes. That would be a game changer for treatment.
I could see that being incredibly helpful. More targeted treatment, faster recovery times.
Exactly. And artificial intelligence is another exciting area. AI could analyze tons of data and help us identify patterns, maybe even predict outcomes. It could revolutionize how we approach diagnostics.
Sounds like the future of URTI diagnostics is going to be pretty high-tech.
Oh, definitely. And I, for one, am excited to see where it takes us.
It's definitely a fascinating time to be in the world of microbiology. So much is changing and evolving.
I couldn't agree more. There's always something new to learn and discover.
Well, on that note, I think it's time to wrap up part 2 of our deep dive. Welcome back to the final part of our deep dive into the world of URTIs. We've covered a lot of ground, but before we wrap up, we need to talk about the elephant in the room, the big challenge that affects everything we do.
You're talking about antibiotic resistance, right?
You got it. It's a major issue in healthcare these days, and URTIs are right in the thick of it.
Absolutely. The AI Gemini document we've been going through really emphasizes that point. It talks about how overuse and misuse of antibiotics have created these superbugs, resistant strains that just don't respond to the drugs we used to rely on.
It's like a constant arms race, isn't it? We develop a new antibiotic, the bacteria evolve, and we're back to square one.
That's a great way to put it. And it's happening with the common URTI bugs, too. Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis. They're all becoming more and more resistant.
So what can we do about it? What are some strategies to fight back against this antibiotic resistance?
Well, first and foremost, we need to be smarter about prescribing antibiotics. This should only be used when there's a clear bacterial infection, not just for any sniffle or cough.
So basically, no more throwing antibiotics at everything and hoping something sticks.
Exactly. And we need to educate patients about taking the full course of antibiotics, even if they feel better before they finish all the pills. Cutting it short can let some bacteria survive and potentially become resistant.
Right. Got to wipe out the entire enemy army, not just a few soldiers. So patient education is key. But what else can we do?
Well, infection control is huge. Things like good hand hygiene, disinfecting surfaces, and promoting vaccination. Preventing pathogens in the first place is always the best strategy.
Absolutely. An ounce of prevention is worth a pound of cure, as they say. Now, speaking of new challenges, the document also mentions emerging pathogens. Any new threats on the horizon that we should be keeping an eye on?
Well, the microbial world is constantly evolving, so there's always the potential for something new to pop up. We've already seen those novel coronaviruses, like the one that causes COVID-19. We got to stay vigilant and be ready to adapt.
It's like a never-ending game of whack-a-mole with these microbes. All right, before we sign off, I want to bring it back to the lab. What are the key takeaways for medical microbiologists like us when it comes to URTI analysis? What do we really need to remember?
I think staying informed about antibiotic resistance is crucial. We need to know the latest guidelines, attend conferences, talk to infectious disease specialists. The knowledge is constantly changing, so we have to keep up.
Lifelong learning, right?
Yeah.
The book's never really close in our field.
Mm,
What else would you emphasize for our fellow microbiologists?
communication. We can't work in a silo. We need to talk to the clinicians, share our expertise, help them interpret results. We're all on the same team, working to take care of patients.
Collaboration is key. All right, before we wrap up this deep dive, I've got one last question for you, something to ponder as we all go back to our labs and clinics. Given all the challenges we've talked about, antibiotic resistance, emerging pathogens, where do you see the future of URTI diagnosis and treatment heading? What's on the horizon that gets you excited?
That's a great question. I think we're moving towards a whole new era in diagnostics, thanks to advances in molecular technology. Imagine having those point-of-care tests that can tell you exactly what bug you're dealing with in minutes. No more waiting for cultures. We could target treatment much more effectively.
That would be incredible. Faster results, better treatment, happier patients.
Exactly. And artificial intelligence could play a big role too. AI algorithms could help us analyze all that complex data, spot patterns, even predict outcomes. It could revolutionize how we diagnose and manage these infections.
It sounds like we're on the verge of some pretty big changes. It's an exciting time to be in microbiology, that's for sure.
Absolutely. It's a dynamic field full of challenges and opportunities.
Well said. And on that note, I think it's time to bring our deep dive to a close. We've explored the world of URTIs, from the common cold to those more serious infections. We've talked about the challenges and the exciting possibilities that lie ahead. I hope you, our listeners, feel equipped to tackle these infections head-on.
I think we've given them a solid foundation to build on. It's been a fantastic journey through the world of URTIs.
It really have. And remember, folks, the learning never stops. Keep exploring, keep asking questions, and keep those minds sharp. Until next time, stay curious and stay healthy.